Good afternoon, our dear students. Today we have a new lecture. It is the lectures from Cycle of Propaedeutics of Internal Medicine, and it is the second lecture from these disciplines. Today I have a lecture for students of MA groups who have first semester of third year or fifth semester. Previous lecture, you remember, it was general with general definition about what is internal medicine, what is propaedeutics, main terms in internal medicine, a little bit about ethics and deontology, and in general about general inspection and additional methods of investigation of patients. And today we start a submodule of diagnostics, signs and symptoms of diseases of cardiovascular system. And today's lecture I want to discuss with you the general moments of diagnostics or methods of examination of patients with diseases of cardiovascular system. Paragraphs of today's lecture are: it is interviewing of the patient, and if previous lecture we discussed in general the meaning of interview, the sense of interview, here I want to stop on moments about interview of cardiovascular patients. It is physical examination of patient with cardiovascular system disorders. Some moments of instrumental and laboratory methods of diagnostics of cardiovascular system diseases. And let's start from interviewing. Previous lecture we discussed that first question during interview is very important. And what are the examples of good questions for diseases of cardiovascular system? I showed you previous lecture. I want to remind you what are the good examples. For example, what is your chief complaint? Or tell me why you are here today. Tell me about your injury. Or what can I do to help you? Or explain me your understanding of your injury. I remind you that questions have to be not specific, not help patient to find some specific disorder in their organism. It have to be quite general to choose the main problem, the main symptom, but it have to be connected with the health of person, not to waste time to other conversation. That's why for cardiovascular system all these questions are okay. During the interview, I remind you that we have to get the anamnesis, and during anamnesis of patients with diseases of cardiovascular system, we pay a lot of attention on risk factors, possible risk factors of different cardiovascular disorders. What the most often of them? Obligatory you note for yourself the age, sex, and race and ethnicity of the patient. Moreover, you should get information about handedness, about high weight, BMI, it is relation between height and weight that indicates overweighting or obesity of the patient, and body type like body form. You note for yourself a primary language of patient, barriers to learning, learner's preference, and unique rehabilitation goals. Okay, chief complaint. Yes, I told a lot of previous lecture about chief complaint. After this first question, you should get information about chief complaint, the main symptoms that disturbing patient. Chief complaint. The medical evaluation of it of a person with suspected heart disease begins with an interview about the patient's major or chief complaint. The process begins from the asking specific questions about complaint. Very often the patient's chief complaint is the chest pain. It is one of the most often situations in cardiovascular system disorders. This table I showed you previous lecture. According to mnemonic dollar, what means description, onset, location, other signs and symptoms, and relief. We can different according to answer of patient on all these questions. We can different is it pain is cardiac, is it pain is pleuritic, or is it traumatic. Other chief complaints in cardiovascular disorders can be shortness of breath, dizziness, blackout spells, palpitations or sensation of skipped, forceful or fast heartbeats, weakness, swelling of legs, etc. Each of chief complaints will prompt a series of specific questions that will help arrive at a preliminary single diagnosis or a group of different diagnoses. If patient said you that, oh doctor, I have a chest pain, it's not enough for you, it's not a chief complaint. You can have to completely characterize this chief complaint. Yes, and if we take like a chief complaint, a chest pain, we obligatory must ask patient about character of pain, location of pain, its severity, timing, duration, and radiation. And you remember, maybe you know that typical radiation for cardiac pain is shoulder, arms, jaw, back, and other parts of the body. Another questions about chest pain. It is provocation. What can provoke this pain? It is relieving conditions. When did it first start? Is it new pain or patient feel it previously? How often does it occur? What brought it on? And is it becoming more frequent with time? Moreover, we detailed where the associated symptoms like shortness of breath, sweating, dizziness, weakness, nausea, vomiting. Are the symptoms lasting longer during time? And do they appear at rest, or has it awakened the patient from the sound asleep? What the quality, what the character of chest pain can be? What is the typical of specifically for heart pain, for cardiac pain? It can be squeezing, like band-like sensation is felt around the chest. It can be tightness. There is a sensation of knot being present in the center of chest. It can be pressure, a sensation of lump in throat or a heavy weight on the chest. It can be chest constriction. The Levine sign is displayed by patients suffering from the chest pain caused by myocardial infarction. The patient typically presses a clenched fist against the chest to illustrate sensation of pressure and constriction of the chest. Burning. It's most typical infarction pain during myocardial infarction, and it's often mistaken for heartburn or indigestion, especially in women. Factors that can influence the pain. It is most often physical stress, emotional stress, cold, sexual intercourse, smoking, meals, and sleeping problems. The intensity of pain we can check according to pain scale in all types of pain, not just chest pain, not just cardiac pain. We usually ask patient about the intensity of the pain according to 10-point scale, where 0 is no pain and 10 it is the worst possible pain. And according to this grade, you understand that it is very subjective evaluation, and patient have to say you what's the degree of pain according to this scale. List of possible more specific complaints, not just chest pain. It can be complaints on a palpitation, dyspnea, cardiac asthma, cough, hemoptysis, edema, syncope, irritability, numbness and tingling, skin changes, and leg swelling. It is the most often complaints of the patients. Non-specific complaints but possible for cardiovascular disorders. It is fever, sweetness, weight loss, fatigue, headache, dizziness, sleeplessness, deranged vision and hearing, voice changes, dysphagia, dyspepsia, thirst, pain in the abdomen, pain in the joints. You see that pain occurs in the heart area. It's nearly in the middle of chest. Substernally, it can be a little bit moved to the left, and according to specific innervation, it can be typical irradiation of pain, of cardiac pain. And here on the picture you see the most typical places of heart pain irradiation. Palpitations. It is feeling of having rapid fluttering or pounding heart. Yes, and here you see the ECG with raised heartbeats in patient with palpitation with some heart problems. It can be typical for a big number of problems. Dyspnea. It is sensation of difficult or uncomfortable breathing. I hope you understand what is that. It can be wheezing, coughing, or shortness of breath due to congestive heart failure. Cardiac asthma. It is breathing difficulty associated with congestive heart failure too. Cough. It is one more symptom of heart failure, and it's possible persistent coughing in this case, not just due to respiratory problem, but due to, for example, heart failure. Hemoptysis. Hemoptysis is the act of coughing up blood or blood-stained mucus from the bronchi, larynx, trachea, or lungs. The most common of this is left ventricle systolic heart failure. Edema. On the picture you see a case of severe leg edema, and it is typical for cardiogenic edema, that is an accumulation of serum fluid from blood plasma in the interstitial tissues as a result of congestive heart failure. Syncope. It is short loss of consciousness and muscle strength characterized by fast onset, short duration, and spontaneous recovery. Irritability and excitation response to stimuli. It is typical for cardiovascular disorders too. Numbness and tingling. There are unusual prickling sensations that can happen in any part of human body, but they are generally noticed in hands, feet, arms, and legs, most often on feet. Skin changes. One of the most often it is cyanosis, and example of peripheral cyanosis, like atypical symptoms of heart failure you see on the picture. During taking a post-medical history, we include other questions about conditions such as diabetes, high blood pressure or hypertension, elevated cholesterol levels, prior surgery, asthma, stroke, cancers, allergies, etc. Prior or current treatment obligatory during taking anamnesis of patient during interviewing. You take all information about treatment that this patient getting now or got it previously. It is information about medications, cardiac surgery, injections, chiropractic, exercise or physical therapy, emergency room treatment, or massage therapy. About previous treatment, we detailed everything the same with other complaints. We ask patient what was this treatment, where was this treatment, when, and by whom you got it. and present status. Is patient feel better or the same or worse after those treatment from the history? Obligatory, important, very important for cardiovascular system, it is taking of family history. Certain cardiac illnesses may occur in more than one member of family. The physician will inquire about the health of the patient's parents, brothers, sisters, and children, or the nearest relatives. In social history, it is important to ask about high-risk behaviors like alcohol, tobacco, or drug abuse, about depression, violence and abuse, about any diet, anorexia, bulimia, and sedentary lifestyle. Signs of any of the above behaviors may warrant referral to a secondary provider. Up to 90% of conditions can be accurately diagnosed or recognized by conducting a thorough medical history and listening carefully to the patient's responses. Determines the necessary tests and measures you should prioritize for your objective examination. I told you a lot previous lecture. Additionally to interview about main complaint and complaints, what we actively try to provoke patient to tell us. After it, more passively, we start to do a review by all systems during interview. It is a laundry list of symptoms related to various organs of the body. A series of questions, they are standardized, helps seek out information that the patient may have neglected to provide a physician. If it, for example, a patient with heart pain, we detailized everything about cardiac pain. After it, another ask about another symptoms from cardiovascular system, detailized if they are present, and after it we start a review of other systems. Review of system helps to identify patient's problem or exclude different parts of the differential diagnosis. For example, you ask patient, it was everything about cardiovascular system, you get all information, and during a review of systems, during interview, you ask patient, do you have some stomach or GI problem? And patient answer, oh, I remember, I had chronic gastritis, but now it is a remission. Is it important information for you? Of course it is important, you have to know it, but actively patient does not remember this information. For these moments we need review of systems. We ask patient by system, like general system. I remind you that cardiovascular was in the main part. After general inspection, it is interview about respiratory system, the most often problems, GI system, the most often problems, genitourinary system, gynecological system, neurological system. One more way to investigate patient, to check such a sign like quality of life. How to check quality of life? It is a general sign of general patient's well-being, subjective patient's well-being, and we usually check it with different questionnaires, and the most often, the most usable of them, we name short form 36 or SF36. It is a 36-item questionnaire which measures quality of life across 8 domains, which are both physically and emotionally based. The 8 domains are as follows: physical functioning, role limitation due to physical health, role limitation due to emotional problems, energy and fatigue, emotional well-being, social functioning, pain, and general health. A single item is also included that identifies perceived change in the health, making the SF36 a useful indicator for change in quality of life over time and treatment. For example, we can check it before treatment and after treatment and check is treatment was effective for subjective patient's well-being or not. Okay, more than SF36, we have another profiles and another questionnaires. It is the most usable. It is DASH, it is Austrian Indices, it is lower extremity functional scale, and others. Physical examination. We, as usual, started from general inspection, and first of all, we pay attention to position of patient. The patient is positioned in the supine position, tilted up at 45 degrees if can tolerate this. It is the most typical pose for investigation. The level of jugular venous pressure should only be commented on in this position, as flattened or steepener angles lead to artificially elevated or reduced level respectively. Lighting should be adjusted so that it is not obscured by the examiner, who will approach from the right hand side to the patient as is medical custom. General inspection. We should inspect the patient's status wherever he or she is comfortable at rest or obviously short of breath. Inspect the neck for increased jugular vein pressure or abnormal waves. Any abnormal movements such as head bobbling. There are specific signs associated with cardiac illness and abnormality. However, during inspection, any cutaneous signs should be noted. Hand inspection include temperature on hands. They can be warm, cold, clammy, or dry. Skin turgor for hydration. On practical classes, you will discuss how to check a turgor of skin. We check for jade vein lesion, what is typical for infective endocarditis. For Osler's knot, it is painful red raisined lesions found on head and feet and caused by immune complex deposition. Splinter hemorrhage, like a quincus pulsation, any deformity of the nail, like Bion's lines and clubbing fingers, and peripheral cyanosis. Head inspection include checking for malar flush, what is typical for mitral stenosis. The eyes for corneal arcus and surrounding tissue, so for xanthelasma. Conjunctiva pallor, the sign of anemia. The mouth for hygiene, the mucosa for hydration and pallor of central cyanosis. The earlobes for Frank's sign. You see it on the lower picture. Precordial inspection, very interesting picture you see here on the photo. It is in very slim and very asthenic patient. It's very visible contours of cardiac stimulator or pacemaker. What else we can find? It is visible pulsations, apex beat, masses, scars, lesions, signs of trauma and previous surgery, permanent pacemaker like here, or precordial bulge. Checking pulses. Mostly we check radial, brachial and carotid pulsation. And we check these places for rate, for rhythm, for pulse pressure, regularity, which can be regular, regularly irregular, or irregularly irregular. For consistency of the strange to assess the pulses alternance, slow rising like parvus, pulsus parvus and pulsus tardus. For jerky like hypertrophic cardiomyopathy and Traub's pistol shot femoral pulse. More about these symptoms on practical. Precordial palpation. The valve areas are palpated for abnormal pulsations, like palpable heart movements known as trills. The precordial movements known as heavies. The apex beat is found approximately in the fifth left intercostal space in the mid-clavicular line. It can be impalpable for a variety of reasons like obesity, emphysema, effusion, rarely dextrocardia. It is assessed for size, amplitude, location, impulse, and duration. There are specific terms to describe the sensation such as tipping, having, and thrusting. There was a time when cardiac percussion was considered a useful addition in the clinical evaluation of patients with heart disease. This skill has been largely lost within the advent of new imaging techniques such as X-ray and Echocardiography, both of which are more accurate in defining cardiac size and borders and detecting the presence and extent of pericardial fluid. When used in isolation, cardiac percussion is prone to error, but when used in a clinical context with other findings, it should still be an valuable bedside tool in differentiating tamponade from acute massive pulmonary embolism until confirmation with echocardiography. It's very important in time in emergency medicine. Heart auscultation. Auscultation is usually performed with the patient sitting up or reclined at about 45%. Sites for auscultation. It is mitral valve area, the apex beat, as the left ventricle is closest to the thoracic cage. Tricuspid valve area. The inferior right sternal margin is the point closest to the valve in which auscultation is possible. Pulmonary artery valve area. It is left second intercostal space close to the sternum, is where the infundibulum is closest to thoracic cage. Aortic valve area. It is right second intercostal space close to the sternum, is where the ascending aorta is nearest to the thoracic cage. The best place to hear the heart valves is not necessarily directly over the anatomical sites. More technique and rules of heart auscultation you will practice on practical classes. And schematically you see sides of the heart auscultation. You see mitral valve, tricuspid valve, aortic valve, pulmonic valve, and Erb's point. It is additional point of auscultation of aortic valve. Normal heart sounds are noises generated by beating heart and resultant flow of the blood through it. The sounds reflect the turbulence created when the heart valves snap shut. In healthy adults, there are two normal heart sounds, lap, adap, that occur in sequence with each heartbeat. There is a first heart sound or S1 and the second heart sound S2, which is two normal physiological sounds. They are produced by closing of atrioventricular valves and semilunar valves. The first sound may be split if there is spacing that triggers the right ventricle before the left, or if the mitral valve closure is delayed by high left atrial pressure or atrial myxoma. The sounds may be softer than normal where there is several mitral regurgitation, immobility from calcification, severe aortic regurgitation, or left bundle branch block. Prolapsed mitral valve or significant mitral stenosis may cause a loud M1. Normally, aortic A2 and P2 are so close that they are ahead at a single sound S2, although they may split slightly on deep inspiration as P2 is delayed. Beat-to-beat variation of the intensity of S2 occurs with complete or incomplete heart block if there is AV dissociation. P2 is delayed and will accentuate splitting in pulmonary hypertension, pulmonary stenosis, and right bundle branch block. Ectopic beats and pacing will delay A2 and cause reverse splitting of the sound. Other hearts and sounds in auscultation include heart murmurs, adventitious sounds like respiratory, and it can be gallop rhythm S3 and S4. They may be heard in young or athletic people. Ordinary are the signs of serious cardiac problems like heart failure as well as pulmonary edema. Heart murmurs are generated by turbulent blood flow which may occur inside or outside the heart. Murmurs may be physiological or benign or pathological, abnormal. Abnormal murmurs can be caused by stenosis restricting the opening of the heart valve, resulting in turbulence as blood flows through it. Abnormal murmurs may also occur with valvular insufficiency or regurgitation, which allows backflow of blood when the incompetent valve closes with only partial effectiveness. Different murmurs are audible in different parts of cardiac cycle depending on cause of the murmur. Here you see a scheme where this it's starting third cardiac sounds in heart value and produce a cadence-like galloping horse or rhythm gallop. If you take 3 fingers and do like this, you can hear a sound like this. A fourth sound occurs in ventricular hypertrophy, ischemic heart disease, mitral stenosis, dilated cardiomyopathy, hyperdynamic circulation, arrhythmia, heart block just before the first, and is an abnormal sound of the AV valves opening as the atria contract. The atrial myxoma can plop during atrial systole and cause late diastolic sound. And we have a scale, we name it Levine scale of heart sounds and murmurs. It includes several grades. Grade 1, it is the lowest intensity, difficult to hear even by experts. Second, low intensity but usually audible to all listeners. Third, medium intensity, easy to hear even by inexperienced listeners but without the palpable thrill. Fourth, it is a medium intensity with a palpable thrill. Fifth, loud intensity with a palpable thrill, audible even with a stethoscope placed on the chest, with the edge of the diaphragm. And sixth, a loudest intensity with a probable thrill, audible even with a stethoscope raised above the chest. Jugular venous pressure. Jugular venous pressure, sometimes referred as jugular venous pulse, is the indirectly observed pressure over the venous system via visualization of the internal jugular vein. It can be useful in differentiation of the different forms of heart and lung disease. Classically, 3 upward deflection and 2 downward deflection can be of jugular venous pressure. The upward deflection are the A, atrial contraction, C, ventricular contraction, and resulting bulging of tricuspid into the right atrium during isovolumetric systole, and V, it is atrial venous filling. The downward deflections of the wave are the X, the atrium relaxes and tricuspid valve moves downward, and the Y descent, filling of ventricle after tricuspid opening. The A wave corresponds to the right atrial contraction and ends synchronously with the carotid artery pulse. The C wave corresponds to right ventricular contraction, causing the tricuspid valve to bulge towards the right atrium. The X descent follows the A wave and corresponds with the atrial relaxation and rapid atrial filling due to low pressure. The V wave corresponds to venous filling when the tricuspid valve is closed and venous pressure increases from venous return. This occurs during the following of carotid pulse. The Y descent corresponds to the rapid emptying of the atrium into the ventricle following the opening of the tricuspid valve. Carotid bruit. A carotid bruit is a systolic sound heard over the carotid artery area during auscultation. Many carotid bruits are discovered incidentally in an otherwise asymptomatic. Any bruit may be evaluated by ultrasound or imaging patient. During physical examination of patient, we should check ankle brachial pressure index. What is that? The ankle brachial pressure index is the ratio of blood pressure in the lower legs to the blood pressure in the arms. Compared to the arm, lower blood pressure in the leg is an indication of blocked arteries due to peripheral artery disease. The ankle brachial index is calculated by dividing the systolic blood pressure at the ankle by the diastolic blood pressure in the arm. And let's start instrumental methods that we usually can use for patient with cardiovascular system. First, and one of the most usable, it is ECG or electrocardiography. ECG is a test that records the electrical activity of the heart. The ECG is used to measure any damage of the heart, how fast heart is beating and wherever is it beating normally, the effects of drugs or devices used to control the heart, such as pacemaker, the size and position of heart chambers. The accuracy of ECG depends on the condition being tested. Heart problems may not always show up on the ECG. Some heart conditions never produce any specific ECG changes. Historical portrait in devices. You see on the first picture it was the first one, and other pictures it is today available the modern ECG devices and monitors, and you see that even small devices like smartphone, like smartwatches can record some parts of ECG. Okay, here you see examples on recording. I'm not going to stop on it because I want to have additional lecture about ECG. Let's talk more there. Holter monitoring. A Holter monitor, it is a type of ECG used to monitor the ECG tracing continuously for a period of 24 hours or longer. The Holter monitor used to suspected frequent rhythm abnormalities, especially ones the wearer may not recognize by symptoms. Atrial fibrillation or flutter, multifocal atrial tachycardia, palpitations, paroxysmal supraventricular tachycardia, reasons for fainting, slow heart rates like bradycardia, ventricular tachycardia, and chronomedicine. Here you see devices. And example of recording. You see that it records just 3 leads, not 12 leads like standard ECG, but it recorded at a minimal during 24 hours. And according to these strips, we can check the rhythm of this patient. Okay, event monitoring. An event monitor records short-term ECG rhythm patterns, generally storing at last 2 to 5 minutes, aiding in a new and discarding all data for 1 to 2 weeks or more. When the wearer presses a button on the monitor, it quiets discarding old and continues recording for a short additional period. These monitors are used to suspected infrequent rhythm abnormalities, especially ones the wearer does not recognize by symptoms. They looks like this, and report examples of event monitors. Here you see just one lead recording. Cardiac stress test. A test used to measure the heart's ability to respond to external stress in the controlled clinical environment. The stress response is induced by exercise or drug stimulation. Cardiac stress test compared to the coronary circulation while the patient is at rest with the same patient circulation observed during maximum physical exertion show any abnormal blood flow to the heart's muscle tissue or myocardium. The results can be interpreted as a reflection on the general physical condition of the test patient. This test can be used to diagnose ischemic heart disease and for patient prognosis after heart attack like myocardial infarction. An exercise ECG is done to find a cause of unexplained chest pain or pressure, discern which treatments are best for person with angina, evaluate patient's ability to tolerate exercise, find the cause of symptoms that occur during exercise or activity, evaluate the efficacy of anti-anginal and antiarrhythmic therapy. Moreover, it can be stressed echocardiography when we do heart ultrasound or echocardiography after physical stress, physical exercises or after stress medicals. Stress test may be accompanied by echocardiography, what I told. It performed both before and after exercise so that structural differences can be compared. The patient is subjected to stress in the form of exercise or chemically induced stress, usually with dopamine. It is used to detect obstructive coronary artery disease. Another test. It is nuclear stress test. It measures blood flow to patient's heart at rest and stress as a result of exertion or medication. The test provides images that can show areas of low blood flow through the heart and damaged heart muscle. Electrophysiology study. A minimally invasive procedure that tests the electrical conduction system of the heart. Minimally invasive, it means that it is mini operation. During electrophysiology study, EPC, sinus rhythm as well as supraventricular and ventricular arrhythmias of baseline cardiac intervals is recorded. The electrophysiology study is indicated to investigate the cause, location of origin, and best treatment for various abnormal heart rhythms. This type of study is performed by electrophysiologists and using a single of multiple catheters situated within the heart through the vein or artery. It is such a look like electrophysiology laboratory. You see, like it looks like operational room that consists of two parts. It is room with the patient and electrophysiologist one that operate the catheters and have monitors with visualization, and room 2 with electrophysiologist 2 and operated who controlled all problem and controlled all indexes of these patients on the monitors. And here you see a lead. It can record a simple ECG, but locally in those places where we place the catheter into the heart. And additionally, for example, if we put catheter to sinoatrial node, we get one rhythmogram to his bundle, another rhythmogram to right ventricle apex and other parts of ventricles, another rhythmogram. And according to electrophysiology study, we can build a 3D map of some chamber, for example, atria. And here you see a picture shows the anterior posterior projection of the enlarged left ventricle with a large scar on the almost all anterior wall. In this map, red color anterior wall, it is a scar. It is no electrical activity here at all. The voltage map of the right ventricle rotated to show the scar in the apex. you see here on this picture in red color. Representative signals from 3 regions within the scar show double potentials, with the second component occurring well beyond the end of the QRS complex. The Wencken-Bach cycle length appears during electrophysiology study. The right atrium is being paced on the right atrium channel. The time between A and V increases until the ventricular signal is blocked due to repolarization of the ventricle as indicated by the T wave. The Wencken-Bach cycle length is 600 milliseconds is significantly abnormal interval. Coronary catheterization. What is that? Coronary catheterization or cardiac cath or coronary angiogram, it is an invasive imaging procedure. It is invasive with catheters too, that test for heart disease by allowing doctor to see the inside of arteries and how well patient's heart is functioning. During the test, a long, narrow tube called a catheter is inserted into the blood vessel in patient's arm or leg and guided to the heart. Contrast dye is injected through the catheter so that X-ray movies and patient's valves, coronary arteries, and heart chambers can be created. You see here result of coronary catheterization or results of angiograms, and you see by the arrows the places of narrowing. Transthoracic echocardiogram or standard echocardiography. Transthoracic echocardiogram uses ultrasonic waves to continuous heart chamber and blood movement visualization. In recent time, it has become one of the most commonly used tools in diagnosis of heart problems, as it allows non-invasive visualization of the heart and the blood flow through the heart using the technique known as Doppler. It looks like this, maybe everyone saw it. And examples of result. On first picture, it is a visualization of heart in two modes. First, it is 2 dimensions result or mode B mode, and lower of it is M mode, 1 dimension result. It comfortable to check a valve working according to this result. And a picture that is on the right in different colors, we see Doppler methodic that help us to checking a blood flow. And it can echocardiogram can be not just transthoracic, it can be transesophageal, because not all structure we can check with catheter placed on thorax. For some structures we need go to the esophagus. Transesophageal echo uses a specialized probe containing an ultrasound transducer on its tip is passed into the patient's esophagus. That is used in diagnosis of various thoracic defects or damage, like heart and lung imaging. Transesophageal echo has some advantages and disadvantages over thoracic or intravascular ultrasound. It looks like this, the transducer placed on esophagus. And result examples, they are nearly the same as transthoracic, but it is more visible some structures. And intravascular ultrasound, also known as percutaneous echocardiogram, is an imaging methodology using specially designed, long, thin, complex manufactured catheters attached to computerized ultrasound equipment to visualize the lumen and the interior wall of blood vessels. Catheter, it is very thin by structure, scheme of its structure shown on the picture. And result shown like this. It goes through the vessel and can visualize on the monitor the inside structure of the vessel. Positron emission tomography. It is an imaging methodology for positron emitting radioisotopes. PET enables visual image analysis of multiple different metabolic chemical processes and is thus one of the most flexible imaging technologies. Cardiology uses a growing very slowly due to technical and relative cost difficulties. Most uses are for research, not clinical purposes. Appropriate radioisotopes of elements within chemical compounds of the metabolic pathway being examined are used to make the location of chemical compounds of interest visible in a PET scanner constructed image. The device looks like this. It's nearly the same with computer tomography, but it is quite bigger. And result exam, you see it like CT2, but much more detailed. Computer tomography and geography. It is a combined method and imaging methodology using a ring-shaped machine with an X-ray source spinning around the circular path so as to both the inner circle with a uniform and known X-ray density. Great development and growth will be seen in the short term, allowing radiologists to diagnose cardiac artery disease without anesthesia and in non-invasive methods. You remember, if angiogram, it is invasive method with putting catheter through veins and going into the heart. With this methodic, it's possible to imagine vessels and their nerves even without injections, without trauma for patient. It look like this. And here you see a result example with visualization, building of vessels and possible checking for some nervings and blocks. MRI. A magnetic resonance imaging or nuclear magnetic resonance imaging, an hematology based on aligning the spin axis of nuclei within molecules of the object being visualized using both powerful superconducting magnets and radio frequency signals and detectors. MRI differentiates soft tissues better than CT and allows the comprehensive exams, including the quantitative assessment of signs, morphology, function, and tissue characteristic is one single session. In general, MRI for soft tissues, it is the best methodic of visualization. In such way, we see a device of MRI. And here result example, you see pictures of heart and its chambers, wall structures, big vessels, etc. Okay, modern technologies that transform the world. There are modern cardiovascular devices for diagnostic become more and more simple every year, and a lot of functions today have even smartwatches and smartphones. Like for example, here you see Cardio Defender diagnostic system. It is a smartphone ECG that can provide continuous reading through the day that can help detect arrhythmias that may be hard to spot in an office visit. Or for example, the modern device, the wireless blood pressure monitor. It is easy and precise self-measurement of blood pressure within personal smartphone. A health tracking wristband that could give healthcare professional real-time information on well-being of their patient. For example, Apple Watches can take these functions. The wearable can measure and patient's pulse, activity level, skin temperature, heartbeat rhythm, light levels, and light exposure. Okay, and little bit about laboratory methods. They are not such an often as instrumental methods, and they are not such an informative like instrumental methods, but they are obligatory for all patients with cardiovascular system disorders because they give you a lot of information about risk factors, about conditions in this patient, and about complications of cardiovascular system. The most often for cardiovascular disorders we use such laboratory methods like blood count or CBC, complete blood count, blood sugar tests, blood test for those taking anticoagulants or blood thinners. We name this test coagulagram. Blood test to determine risk of coronary artery disease, and B-type natriuretic peptide or BNP blood test. Moreover, we should check the most of patients for electrolytes, for enzyme protein blood tests, lipid blood test, thyroid blood test, and relation urine albumin creatinine ratio. Blood thinners or coagulagram. Here we check for prothrombin time, for international normalized ratio or ENR. You see norma here, and ENR, it is a very important measure for patients who are on anticoagulants, especially indirect anticoagulants, warfarin. ENR, it is a way of controlling and choosing of dose of warfarin for such patient. Test for determining risk of coronary artery disease. It is lipoprotein A that is associated with higher risk of heart attack and stroke, desirable level for adults less than 30. Apolipoprotein A1, it is a major protein of high-density lipoproteins. Low level is associated with increased risk of early cardiovascular disease. Apolipoprotein B or ApoB found in cholesterol particles. ApoB may be a better overall marker of risk than low-density lipoproteins alone. And goal values you see here. Bnp blood test. Non-traditional blood protein made in heart and found in the blood. High levels of B-type natriuretic peptide are associated with increased risk of cardiovascular disease, heart attack, and heart failure development. Elevated levels are associated with development of heart failure and worse prognosis. Goal values of it are less than 125 picograms per milliliter. Enzyme and protein blood test. We check, I will not read the normas, you can fix it for yourself. I recommend you to write to the conspect, because during the practice, during some testing, you will get questions with clinical cases with some signs, and make for yourself the normas for main laboratory methods for quicker checking for the specific patients. We check enzymes and proteins for cardiovascular system. The most often it is alanine aminotransferase or ALT, aspartate aminotransferase or AST, creatinine kinase, lactate dehydrogenase, myoglobin, and troponin T. It is myocardial infarction enzymes. Lipid blood tests. Here we should check a total cholesterol. High levels of them put patient in increased risk of heart disease. And fractions of cholesterol. It is low density lipoprotein cholesterol. Too much of it in blood causes the accumulation of fatty deposits or plaques in arteries, what we name atherosclerosis, remember from pathophysiology. Moreover, in lipidogram, we check for high-density lipoprotein cholesterol. Ideally, high density should be at 60 milligrams per deciliter or higher. And we should check for triglyceride. High levels of it increase of heart disease. C-reactive protein. CRP, it is a sign of inflammation. It is non-specific inflammation, not just cardiovascular system, somewhere in the body. But we should check, like general checking, is it present inflammation or not in a cardiovascular patient. We do it nearly in all patients. Inflammations play a central role in the processes of atherosclerosis, in which fatty deposits clog arteries. CRP test result can be interpreted as putting heart disease at low risk, overage risk, or high risk according to C-reactive protein level. Thyroid blood test. Here are the most often screening test for all patients. It is TSH level. Its normal range from 0.4 to 5.5. Additionally, if you find some changes in TSH or patient previously had some thyroid problem, we should prescribe patient test for thyroxine or T4. And usually we use microsomal thyroid antibodies or TPO. Ratio urine albumin creatinine. Albumin, it is a protein found in urine that can be a sign of increased risk for kidney disease, diabetes complications, and cardiovascular risks. If elevated level of urine albumin to creatinine are present, close attention to blood pressure control, including use of specific blood pressure medications that help protect the kidney, may be recommended. And goal values of this relation is more than 30 milligrams per gram indicates increased risk for cardiovascular disease and diabetic nephropathy, and more than 300 milligrams indicates clinical nephropathy. That's all that I want to discuss with you today. Of course, it will be more information about general inspection, about examination, about additional tests of cardiovascular system. We talk more about him on the next lecture. Next several lectures will be about specific syndromes in cardiovascular system disorders, and in each syndrome we discuss more about methods of investigation. For today, that's all. As usual, if you have questions, if you have comments, I wait for your feedback in comments under the video on YouTube or in our Facebook page. Please leave your name and group numbers in the comments under the video, and see you in 2 weeks. It will be a lecture about arterial hypertension. For today, that's all. Goodbye.